My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. And welcome to this episode of Operate with Zen. In this episode, we're going to talk about complications, but not so much the actual complication, but what happens after. And the impetus for this is severalfold, but two important things. We're going to talk a lot about complications in upcoming episodes, and we're going to talk to surgeons about their experiences and how they deal with them on an individual basis. And the reason for doing that is, or one of the important reasons for doing that is a lot of trainees and people ask now, say, listen, that complication or that issue or that bad outcome is really weighing on me. And I think this is a universal experience for all of us who are in medicine, whether it's surgical complication, medical complication, or issue with dealing with a patient when things just don't go well. And there's a lot of emotions and things that are associated with that can really have detrimental outcomes if they're not addressed. And we do not talk about this. We don't address it. So part of today is giving kind of the framework or the foundation for discussing complications and what comes after, and hopefully moving together to a better, more healthy place to deal with issues. One piece of advice, I'm going to hold up a book called Attending by Dr. Ronald Epstein, who is a primary care physician, but really talks about mindfulness and a mindful approach to medicine, and spends a lot of time talking about complications and how that weighs on us as physicians. So we're going to start with a quote, as we often do in these solo episodes. And this is by Thomas McCrae Osler, who was not related to Sir William Osler, but one of his colleagues. And he said, more is missed by not looking than by not knowing. And when we think about misdiagnoses or things that go wrong in medicine, they fall into several categories. Misperception, something you didn't see. Misinterpretation is a misjudgment of a significant finding, or misprioritization. You relegated something that was actually very important to less important because it didn't make sense to you. And then the last real issue is closed-mindedness. And this is not being open to alternative explanations. And this is something we work on with all of our trainees, whether you're in medical or surgical fields. And if you actually break this down, a lot of these misdiagnoses, as we talked about, are similar or fall into categories of the heuristics, which we talked about in the decision-making podcasts. What about in surgery? You could actually use the same categories that I just described, but in general, we break mistakes down into two large bins: mistakes of judgment and technical mistakes. And either way, the most important question to ask after either complication or bad outcome happens is, can you learn from the mistake? And the answer has to be yes. If you can't learn from a mistake, you're destined to do it again and again. And you really need to think about what you're doing in surgery. So how do we learn from mistakes? There's just my 2 cents, and there's lots of ways to do this, but the first part of it is owning it. The second part is remembering it. And the third, I think, is engaging either others or engage a systematic solution to prevent it from happening again. And what this does is it brings it full circle. You own it. This was my issue, or an issue that happened to my patient. You internalize it. You remember it. But you don't dwell on it. You pack it in there so it's there. And then you work towards a positive solution. And for instance, we see this. I mean, this is where timeouts and site identification have come from, right? For wrong site surgeries, multiple checks to make sure that correct site surgeries happen. Yet, guess what? Wrong site surgeries still happen. So you can think about a safety mechanism. For instance, let's say someone, this is easy in oncology. We've got tumors or cancers that are easy to identify. Sometimes in reconstructive surgery or some other surgeries, you may not have a visible lesion. So maybe bring in some other primary documentation as part of your timeout to make sure everyone is on the same page and identifying the correct site for surgery. The other part of surgical mistakes are technical mistakes. And the big question here, most things that we attribute to technical mistakes are actually mistakes of judgment. You cut somewhere you shouldn't have cut, or you pulled on something you shouldn't have pulled on. But we put those into the category of technical mistakes because it often involves physical movement or physical motions. The main question here is, once again, can you learn from the mistake? How can you engage something systematically to prevent it from happening again? But importantly, if you're really truly making a physical technical mistake, you have to think about, can you physically, technically perform this procedure or this portion of the procedure? And there's nothing wrong with engaging other colleagues or going for additional training to make sure that you can safely perform a portion of the operation if you're concerned. And the last part to consider when you're thinking about solutions of your complications or bad outcomes is, what is the context of that mistake? Were there any external forces that contribute? And in one of the first podcasts, we talked about the airline industry and airline mistakes. And if we go back to that plane crash analogy, yes, there's usually a minor technical malfunction. There's often a tired pilot and poor communication, but almost always involves bad weather, some external context. And so improved solutions for the airline industry were obviously improve communication, sleep regulations, break down the hierarchy for communication, but also avoid poor weather contexts and really trying to avoid that perfect storm of bad things happening. Well, what's that external context in the operating room? Well, this could be our physical space, right? Is the operating room loud? Is it conducive to safe work? Some people like loud music, some people don't. Some people like chatter in the background, some people don't. So set up the physical context so it's a safe working space for you. And probably the bigger part is the emotional context. The operating room and where we are needs to be a safe working space. So if you have stress going on in your life, whether it's in medicine, in your home life, wherever it may be, you've got to leave that outside of the operating room. So detaching from it, not forgetting it, not pushing it away, but detaching from it when you're in the operating room. You have to think about, are you in a burnout situation? How are you doing on your kind of burnout feelings? Because being in burnout can really decrease your mental capacities, your ability to think through things, and contribute to you making judgmental mistakes. And the last thing along those lines is something called recovery failure. And Dr. Epstein talks about this a lot in his book, but basically recovery failure is related to cognitive load. And basically when we're under high cognitive load, if we've got difficult problems, too much info going on, added to emotional stress, right? This is once again the perfect storm that we see in the airline industry. Our brains actually simplify things to the familiar and the expected. So we can overlook nuanced care. We can make simplistic decisions in a situation that is not simple. And this is where mistakes can happen. Recovery failure is therefore the time that it is needed for the brain to recover between tasks. And the main contributor to recovery failure is when we have too many switches. We change our context, we go back and forth. And we see this now, particularly in contemporary medicine in 2022. We're on an electronic medical record, then we're on a phone, then we're texting with a resident, then we're talking to our assistant here, then the operating room's calling. More switches we have, the more likely you are to have recovery failure. And the more time you need to recover between tasks, once again, can lead to judgment failures most commonly. So now something's happened, a bad outcome, a complication. Our patients are struggling. We're struggling. George Engel was a psychiatrist who really studied the biopsychosocial model of health and said that physicians, we're humans too. And we have emotional responses to tragedy, grief, and loss, particularly when they happen to people we care for. And we care for our patients. It may not be the same care that we express to our children or our family, but we genuinely care for them. That's why we do what we do. And we certainly experience tragedy, grief, and loss when they experience tragedy, grief, and loss. And if we don't address it properly, it can affect the care we provide. Another part of this, or another concept here, is something called compassion fatigue. And we really, in medicine, when we don't address our emotional lives, when we don't address what Engel called kind of the psychological and social determinants of mental health, we can see our own empathy and compassion decline. and it can affect our relationships with our patients, and it can affect our decision-making. And one of the really important concepts to know here is something called second victim syndrome. And I don't know if he created it, but it's certainly attributed to Dr. Albert Wu, who was at Hopkins and one of the kindest, smartest physicians you'll ever meet. But second victim syndrome is defined as when healthcare providers who commit an error or are traumatized by an event that manifests psychological, cognitive, or physical reactions that can further have a personal negative impact. And when we talk about psychological manifestations, this is the shame, guilt, anxiety, grief, and depression associated with a complication or bad outcome. We have cognitive issues, so compassion, dissatisfaction, burnout, secondary traumatic stress, and literally physical reactions, anxiety, difficulty sleeping. All of these things contribute to second victim syndrome. And Dr. Wu says in that paper from 2000 in the British Medical Journal, virtually every practitioner knows the sickening realization of making a bad mistake. You feel singled out and exposed, you agonize about what to do, and later the event replays itself over and over in your mind. And I talk about this a little in the beginning when I said when you have an issue, when you either have a complication or a bad outcome for your patient, you need to own it, remember it, and then engage in a positive outcome or in a positive solution. And the problem becomes when we don't engage in the positive. And there's this bad cycle where you have a bad outcome. There's either lack of support that is tangible or perceived, puts a physician at greater risk of depression and burnout. Because of that, you become distracted, less emotionally available, less empathetic, which leads to loss of confidence, fear of another mistake, which actually makes you more likely to make another medical mistake. And this is discussed in depth in Dr. Epstein's book. If you like where we're going with this conversation, I would encourage you to read more into that. So embrace your mistakes. Remember, it's not just the technical issue or the judgment issue, but how do we respond to these things emotionally and psychologically? And we cannot be haunted by our mistakes, except we have to recognize we're all imperfect. We have to allow kindness and compassion, not only for our patients, we should feel bad for them, but we do have to feel kindness and compassion for ourselves. We didn't hurt anyone on purpose. Things happen in medicine. Often this is biology and not necessarily something we've done. It's often something we could have done better, but in retrospect, it's really hard to judge that. And it's only by allowing kindness and compassion for yourself that you can feel less encumbered and do your job better. So I'll leave you with one final quote, which was put on the epitaph of an Athenian doctor in 2 AD. These are the duties of a physician. First, to heal his mind and to give help to himself before giving it to anyone else. So take care of yourself, so you can take great care of your patients and your loved ones. Thank you for listening.